And good evening, everybody, and welcome to the Oculus Clinical Webinar Series. My name is Dr. Bill Tulo, Medical Director at Oculus, and tonight I'm really excited to have Dr. Chantel Garcia talk tonight about dry eye. Are you all in? Before I introduce Dr. Garcia, a little bit of housekeeping. If you have questions tonight, please place them in the chat, and we'll do our best to answer all your questions at the end of the presentation. Dr. Garcia's professional journey reflects a steadfast commitment to providing lasting solutions for intricate cases. Having completed a cornea and contact lens residency at PCO or SALIS, she spent over a decade as an adjunct professor sharing advanced knowledge of contact lenses on both national and international stages. Transitioning from ophthalmology, Dr. Garcia established Carolina Eye Doctors in North Carolina, a thriving cold start practice now in its 6th year, specializing in medical contact lenses, myopia management, and ocular surface disease. Beyond patient care, one of Dr. Garcia's greatest passion lies in her role as the co-founder of Immersion, an implementation advisory group focused on seamlessly integrating specialty ocular surface disease and aesthetic services into primary care practices. Dr. Garcia brings a wealth of expertise. Notably, one of her recent key contributions to eye care was serving as one of the primary investigators in the latest study exploring the synergy of RF radiofrequency and IPL, intense pulse light. With no further ado, Dr. Chantel Garcia, take it away.
Hey, Bill, thank you so much. And thanks everyone for joining this evening and having a chat with me about dry eye implementation and really the journey of how we can use our diagnostic tools to either advance some protocols that we already have or really challenge our offices to perform at a higher level. And so let's see if we can get that. Like Bill said, I'm going to go over the evolution of my office and how I journeyed into being one of the co-founders of OD Immersion, because I spend 2 of my days out of the week in patient care, going over, cornea, contact lenses, ocular surface disease. And then I spend 3 days of my week talking to colleagues through the nation who are following the same pursuit as far as implementation and advanced procedures within the office. So after that, I want to try to just go over how critical the Keratograph is to clinics, what features we can use to get started, and how to implement that in terms of screening, language of conversion, what key items we can use to discuss with our patients so that they understand what we need as far as diagnosing and treatment, and then of course the importance of our teams. So my journey is important because it's backwards compared to a lot of my colleagues. And as mentioned, my office, after I ventured out through the specialty worlds of ophthalmology and working under cornea specialists in terms of always being tertiary care and rehabbing corneas, I decided that I was going to open cold, be brave, get some grit, and decide that private practice is where I wanted to be. And so I started Carolina Eye Doctors, and I got the common question of what the vision of my practice was. And like every cold start, the vision is simply to pay your bills. And so I really wanted to make sure that I could, serve the population, get a patient base in the door, and establish, a healthy clinic before I could really jump into my specialty. However, I always saw my patients under a different lens, and that was under the cornea and contact lens clinic. And so initially I wasn't a referral only clinic, but I commonly got the question from colleagues, where did I find my specialty contact lens patients? And I always said, they're in your chair. They're always in your chair. It doesn't matter if it's a multifocal you were looking for or a custom soft design. Anyone who has high astigmatism that you can offer other lenses, you have to be brave enough and you have to sniff them out and you have to provide the option. Without providing those options, right, we can't convert into any of these specialty clinics. And so I got started and I wanted to make sure that from a financial standpoint, I could open as low as cost as possible. And so I bought a lot of my equipment cold from an old office, and it was older. And 2 topographers in, my office looked like the 1980 Vision Expo. My topographers corrupted day 1. And so since I had been practicing for quite some time, I really didn't need the topography to fit lenses. I felt comfortable that I had fit so many lenses, we could get started without it. But I knew eventually that I needed something to track, diagnose my patients, kind of supplementing with the ophthalmologist down the street as far as Pennicam goes with cross-linking and such not. And so after a couple months, I decided, hey, I need something. And amongst everything, my biggest and first purchase was the Keratograph. And so with the Keratograph, there was a couple reasons that I decided to make that my first purchase. I knew that I wanted a topographer, and this was back in 2017. And so at the time, I really didn't know anyone who had the Keratograph, and I wanted to take a look at the features that could not only supplement what I needed as a contact lens specialist, but then offer other options that I didn't have within my clinic. And so the topographer was important as far as just simply diagnosing some of the keratoconic patients, but then also gave me the option to continue to expand orthokeratology and even some of the wave designs. Another thing that I thought that was really important with the Keratograph was just the option for imaging. So I was like, that's something that I don't currently have in the office, and it's going to give me videography and allow me to image to the patient so that I could show them some more of the diagnostic tools. And of course, it had a dry eye suite. Now, at the time when I did this, I thought to myself, well, the ROI on topography is pretty low. You don't buy the topography for that. You buy that to, invest into contact lenses, and that's how you really start to see those changes. But with the dry eye suite, I said, this is new. I can make something of it. Let's go ahead and be creative. And so initially, I like to kind of review what my initial implementation efforts were. And so I thought to myself, okay, with the dry eye additional piece, I can charge for some evaluations. And I did. I started off at about just under $100 and decided that I can run an entire dry eye report, and they could elect into it either in their paperwork at the, when they were doing their paperwork online, or at the exam with the technician, because I was only seeing maybe 2 people an hour. And so if they wanted to elect into it, I could run this report. $99. It gets me a step closer than just the few patients who needed topography. And of course, it had anterior segment camera, and I could, start charging for some of those. So I really went into looking, how can I make something more beyond just contact lenses themselves? And so it has the crystal tier report, which is beautifully laid out and gives you the option to tell the patient if they're, normal, mild, moderate, or severe in a couple different categories. And so for those of you who do not have a Keratograph, it gives you some of these options as far as corneal staining. So you can put fluorescein in and image those, and that can be very powerful. Instead of having to say to the patient, just like your hands kind of crack in winter, the surface is the same thing, you can demonstrate it to them, which I have found to be an extremely vital tool for the patients to understand exactly what is going on. A lot of patients, if you ask them, are your eyes red on occasion, they kind of think about it, but if you show them the redness scan, or if they look under it under a microscope, they go, do they really look that red? Because everything is magnified. So it gives us those 2 options, press a non-breakup tear breakup time. You can measure tear meniscus height for any aqueous deficiencies. And then of course, it also gives you mybography. So there's a couple different elements, and you can customize this report, but I thought, gosh, this is really powerful. This is additional testing. I'm going to go ahead and charge for it for those patients who want additional testing so that I could be compensated for my time and expertise. And so I was not successful with that first attempt. And so I did learn quite a bit, and I pivoted towards some different options. And so like most clinics that we hear, there was a couple concerns on why I failed during this. And so some common screening hurdles that I tend to hear, number one is always time. When you only have 2 people an hour that you're seeing, you have additional time. But what if you're a clinic that has more than 1 doctor? You see patients every 15 minutes, every 20 minutes. How is it possible for us to run all of these tests? More importantly, there's the more diagnostic tools that we get, they all flood into a single pretest room. And oftentimes now the newer pretest rooms have the model where you can put more than 1 patient. But if there's only 1 room, then I'm worried about flow constantly being backed up. And then those tests require a skill set, right? The technicians have to learn how to properly align someone, maybe flip an upper lid, measure appropriately. And all of this just bogs down the screening process. And so Like many practitioners at the time, I ran into some trouble. And most of it was commonly what we see here. And then I also found out that people didn't want to pay for that specific model. But I also learned that it was an important tool to have. And so what I challenge ourselves is, at the time, I didn't have any advanced treatment options in my office for treating OSD. I didn't have a tear care. I didn't have a LipiFlow. I was a cold start, and I was just obtaining the information. And so for the couple patients that I ran the screening on, I really was intrigued by information I had not previously had access to. And so I challenge you today by saying, if we took away all of the treatment tools that you use for treating glaucoma, could you effectively treat glaucoma at the level you treat currently? And so most of us have gotten accustomed to these tools. It's like fundus photography. A lot of us have Aiden or Optos, and we've got accustomed to that level of care, and we use that in our practice. So as I started collecting some of the patients who wanted to, and they were certainly the symptomatic patients who wanted to find out additional information as to what was going on, I got spoiled with the extra data. So I thought to myself, okay, there's some validity to running the test, but I'm having an issue with screening in terms of time, efficiency, and I can't be the one who always runs these tests. I need a technician or someone else to support me. So I went back to the drawing board and tried to challenge myself with, okay, what do I actually need? And so I ask practitioners all the time to say, select the most vital parameter that adjusts your clinical decision making. All of this data is important in different cases, but sometimes you get too much data and then you have to explain the data off. So that's what I challenged myself to do. And I thought to myself, okay, what do I actually need that I cannot get under the slit lamp? And how do I effectively get that into my screening process so that I can still use the information? And so for me, that big aha moment was mybography. All these years we were treating patients to some degree, successfully, unsuccessfully, with just drugs and drops, right? How many times have we heard the story that the patient was on Restasis, it really didn't work, and they're back again? And so one thing that I learned when running the Crystal Tear report was, gosh, we were missing so many glands. And it became evident that the stats that we always knew that existed were in my chair. And I was missing it. For over a decade of practicing medicine, I was missing all of these patients, and I knew the report to be true. Constantly, we see the data. Millions and millions of Americans have dry eye disease. Now, if we are looking for it, if we're asking for it, if we identify it, that's a different question. But all those years, it was in my chair, and I just wasn't addressing it, or the patient was tired of explaining it out, or was just told to use artificial tears, and we were kicking the can down the road. But what we do know is that almost half of the visits coming to your office, patients have a complaint of dry eye disease to some degree. And in my office, I try to use the word inflammation because the patients will say it's itchy, burning, red, dry. They'll describe it to something other than dry eyes. They will kind of brush that under the rug just a little bit. But more importantly, 81% of patients are frustrated. They're looking for additional relief. And so as I started running mybography, and the patient maybe didn't elect into my screening protocols of the time of paying a fee to run the diagnostic, I thought to myself, gosh, send them back to the device. What does it look like? I realized that I could not properly come up with a treatment plan without understanding what was going on. And so currently, if we think about that, I always like to correlate it to glaucoma. We screen every patient coming through our doors through IOP. We may do IOP and fundus photography. We're taking two elements, and from there, we're determining, do we need to do something extra? So if you currently have Keratograph and you're not using it on every patient to some degree, or you're not using, symptom scores, then you're not really screening for it. And so for my practice, that was the big moment that I knew that I had to start incorporating some level of screening on every patient. And so as Oculus holds these webinars and they provide such great information, especially if you look at the topic as far as dry eye disease, what I will attest to is there is the single most important shared element upon top performing practices. It is not a secret, it is screening. All of us and all successful practice have figured out how to properly and effectively screen the patients. Without screening, you cannot identify. Without identifying, you cannot converse. And without conversing, you can't treat. And so screening is the biggest thing that we need to go back to and figure out, how can I proficiently get this into my office? Screening every annual patient is always the goal. If you fail to screen, you are without a doubt risking revenue, because you're not identifying these people, and not all of the patients are going to have it as their primary top concern. So it is the primary pillar to conversion of any in-office therapy. Now the question will remain, how to screen, what do we screen with, who runs the test, do we charge for it, yes or no? And the flavor of that is going to look different for every single office, but one thing we know is that we have to screen our patients. So upon screening the patients, we first have to identify what our clinical model is. And there are two different divisions that we will see in practices that succeed. The first one is understanding and screening through just your comprehensive annual exams. And a lot of this has to do with your clinic volume. Some clinics are set as a single doctor, 2 doctors in a single location. Some clinics are set for 5 doctors in a single location, or multiple locations with less doctors. And the equipment may not be at every office. So when you sit down and you're figuring out, how should I properly screen, we need to think about how your clinic is currently set up. And so as I go through the options in determining the best way to set up your screening protocols, I'm also going to share with you what we do in my clinic. And so for the first category, it would be that we are going to not only screen for our comprehensives, but you're also going to try to have the conversations of advanced treatments during those annual exams as well. What this allows us to do is simply cast a wider net. So you're going to get both asymptomatic and symptomatic patients alike. But if you do it that way, it is a lot of people. So we need to have fewer diagnostics, and our conversations need to be direct and concise. Now, if you come up with something and you determine that additional testing is always needed, that's the case where you can have the patient return for a more detailed, comprehensive evaluation. But at least, again, in terms of IOP or fundus photography, you're capturing some data on everyone. And most clinical settings evolve into some type of screening for every patient, because we realize how powerful, or maybe how much we're missing by just simply asking. By the time the practitioner has asked in the exam room, it's usually too late, because they're not thinking about it as much. If it's on your paperwork, if your front desk person asks for it, if the technician asks for it, they're already starting to think about that conversation. If it gets past all of that, and then you ask them, do you have any dryness, itching, burning, then you're spending a lot of time trying to figure out what's going on, rather spending time on figuring out how to resolve it. So the first clinical model would be casting the wider net and running it for the evaluation for every patient that walks through the door, and coming up with a treatment option and prescribing from the chair on every annual exam. The second option would be to have patients come back for a dry eye evaluation. Now, in this category, there's typically screening of some kind, but this would allow for more selective candidates that are likely more serious about their condition. It would allow for a more comprehensive approach where you can devise a detailed treatment plan and more detailed conversation of their OSD and what the proper, treatment would be. And so whether you're bringing the patient back for an evaluation, or if you're screening every patient, you kind of have to decide what works with your clinic flow. And sometimes it's a combination of both. Maybe you just do a symptom survey on everybody, but then bring them back for more detailed evaluations on the keratograph itself. So a lot of that information can switch back and forth as your clinic evolves. But what I challenge you today, whether you have a keratograph, whether you're wanting a keratograph, or if you have in-office treatments or wanting to advance in-office treatments, is to pick a category that we're kind of chatting about and have your clinic level up from where you currently are. So the first thing is to determine what kind of clinic setting are you going to get set up in your office. And so there are a couple different screening tools, and usually a combination of both is going to be the most effective. Symptom surveys are actually very powerful. And so, of course, this is something that you likely won't charge for. It's going to be free. It can be put in your paperwork. It can be put on your website, but allows us to understand and orient their symptoms. right? How much are they suffering? And so those patients that are much more symptomatic are likely going to be more serious about electing into cash pay procedure as opposed to those that are asymptomatic. So it's going to help aid us in who's going to be more serious between those conversations. Now, as far as the Keratograph goes, it provides us the objective clinical point. This is the disease process. You know it, I know it, and somehow we have to portray that to the patient. Oftentimes we're prescribing, and it doesn't even matter if you're doing something like just warm compresses at home, or if you're offering some ocular products for blepharitis, but we're normally talking only about the symptoms. And by using the Keratograph, you allow for an objective clinical point of view, and that is a stronger foundation for identifying and prescribing. Now, with the Keratograph, you do have the option to provide fees. Now, initially, I did not succeed with that model, and it's not because it doesn't work. It's how it was set up in my clinic, so to speak. And I simply found that patients were very likely to pay for the treatments once I figured out what was going on, but really didn't want to pay me to figure out what was going on. They kind of felt like that was my fault. I'm sorry, my job. And so as far as the Keratograph goes, I do still have a combination of both of these in my clinic. And so if someone is referred into my clinic specifically for an ocular surface evaluation, we do have an associated fee because I want to be able to be compensated beyond a level 2 in my clinic. However, we do allow that to be credited towards an in-office treatment if that's something they need. I do this with diagnostic with contact lenses as well. If just today someone was referred in, should they need a transplant, can they wear contact lenses? There is a diagnostic fee for that. And if they choose to move forward into a contact lens, then it is credited. And then that way, when the patients come in, they know that there's going to be a fee for this service. And that evaluation looks far more comprehensive than if you're just here for an annual exam. And so if you're a clinic that has a high volume, maybe you want to do a combination of those. Maybe you want to start with a questionnaire, and it can be an OSDI, it can be a speed, anything you find to be quick and easy to gather data. And you can set a protocol that says maybe on speed, they're symptomatic with 6 and above. I'm going to set them on the Keratograph. And so it can still allow you to be efficient in screening those patients and identifying those that may be symptomatic, since they're going to be more likely to address anything as far as in-office procedures go. So the objective findings help us validate the patient's symptoms, but we still need to prescribe objectively. And so for those of us, again, that do not have the Keratograph, I do want to review how I utilize this in my office. And so I knew that all of this information was extremely vital, but I couldn't run it on every patient, especially as volume increased. It does take a lot of time. And in my office, we screen for quite a bit. We have NeuroLens, we have the myopia master for our kiddos. So we're running a lot, and I needed to figure out what did I need before they got into my chair for me to make a clinical decision. And so I was compelled by the photos that are provided by the Keratograph, so much so that before I could invest in all of my fireflies, I had an attachment that I would just put onto my rooms, and I would carry that around to be able to show them in the slit lamp exactly what I was seeing. And so the first 3 images on the left-hand side, I currently do that in the exam room, right? And so I have the luxury of having my fireflies now, but even before I had them, I could see that information behind the slit lamp. And so I slowly started to eliminate staining from my pre-testing. Redness was probably the one that I dropped off the quickest, just because you can see that objectively. They can see it, you can see it. Tear breakup time is pretty powerful just because it helps us explain away why vision fluctuates over time. But again, it became something that I could do under my slit lamp, and whether I could demonstrate it to them or not, at least I could get the information within my chair. So remember that my clinic currently serves as we screen everybody, and I was looking to figure out what could I drop off and still provide compelling information to the patient of if I was missing something. The tear meniscus I really do love, especially as far as aqueous goes, and helps me identify what I'm dealing with. But again, it's something I can really see underneath the microscope as well. So as I mentioned, my biography is really where I landed. And so for my Keratograph on every single patient, we run my biography. If you are 18 or over, if you're a contact lens wearer under 18, you get mybography whether you're symptomatic or not. So we run a speed within our paperwork, and it doesn't matter the speed because I did identify, and the reason that I did this over time is so many asymptomatic patients were sent to the office, and the moment we ran mybography, they would say, why didn't anyone pick this up before? And a lot of times that they don't have the technology. But if you have the technology and you're not running it, I can reassure you, you're simply missing it. And so that was the one thing that I couldn't get under my slit lamp that I said, I need it to occur on everybody. Now the question will remain, I get this quite a bit, is do we do upper lids? Do we do lower lids? And a lot of that is going to be based off of how proficient your team is. And so of course, lower lid imaging is easier to get. It's less invasive for the patient, so they can just simply look up, gather that image, and the Keratograph does a wonderful job, and I'll kind of demonstrate it in just a second, of how it shows you progression over time and where the patient's eye lands in that. And so it not only is vital information to demonstrate with the patient, but as you can see in the lower image, it's kind of disgusting to patients. And so if you show them that image, sometimes I can't even ask them about their families or their kids. They're immediately saying, what is that and what's going on, right? And so they are immediately drawn into the conversation, and that helped me get started with everything. So I, in my clinic, run upper lids. I just find that it has a long-lasting impression on patients. If the upper lids have complete atrophy, then we'll run lower lids. But as a screening tool, to be quick and effective and push everybody through the office, we flip lids. And because my technicians flip lids all day, every day, they are very quick. I should time them from start to finish, but I can tell you it is faster than them running the 3 images on my AIDN, and a little bit longer than them running my autorefractor. So it is pretty quick at this point, and I can just look at the image, and whether they're symptomatic or not, know that whether I have to have a conversation. If you're asymptomatic, but you have gland loss, we're going to have a conversation about it. That is my job. And now that I have the Firefly, of course, I can match that to what I am seeing. But if I need them to return, then we can sit them back down and go through the Keratograph's complete report, show them in each detail where they are, and evolve that conversation just a little bit more. So you really can customize this. This is what's wonderful. I call the Oculus team quite a bit about the Keratograph, and so they have a support line you can call into if you want to customize this. And currently, if you have it and you're like, you know, I ran the report, it was just too much, I want to run tear meniscus height and mybography. Have them kind of set those 2 elements up so that your technicians just go in and run those. Maybe you want to run a redness scan in your mybography, or your non-invasive tear breakup time in your mybography. But simply, you can go in there and set up those 2 elements. That way, the technician knows what they're running every time. If you decide you want to run just simply mybography and bring them back for a more detailed evaluation with the other additional elements, you can have them go in and set that information as well. So it gives you the option to customize it for your clinic. And so what I found that mybography was important is not only the identification, but also determining severity. I'm going to respond very different to a 30-year-old who has 20% gland loss than a 30-year-old who has 80% gland loss. You know, and my associate and my team will ask me quite a bit, well, how much loss is too much loss? And I'm like, any atrophy is atrophy, right? It's just the same thing if we're dealing with the optic nerve. If there's any adjustment to the nerve fiber layer, we're concerned about it. It should not exist. And so it allows me, though, to have an impression of their clinical setting and their objective findings so that they understand my level of concern, right? And so it's always making sure that the patient's level of concern meets your level of concern, so there's an action item taken course. And so it's like telling the patient that they have a retinal detachment in the back and they're worried about their astigmatism. There's a disconnect of level of concern, and the photography allows for us to meet the conversation in the middle. And so after we have kind of identified what kind of clinic we want to set up, whether we want to, treat patients and provide treatment options from a comprehensive or bring people back for full evaluation, that helps you determine, well, should I just run a more simplified screening approach, or can I do a full comprehensive? So if you're someone who's bringing people back for an evaluation, you can absolutely run the entire report, and it has the full clinical picture in there, and those patients are serious about taking action, right? So when we then get the question of, do you charge or not charge, one of the reasons that I didn't succeed initially is that there was a disconnect with what I was presenting. I was running it through my annuals, which should have served the no charge model. I wanted to just capture the data to understand how I should prescribe accordingly, especially based off of the severity. So to charge or not to charge really determines what kind of clinical model you're setting and what type of elements you're doing within that. So on the no charge portion, this is us to broaden the scope and to help identify the masses and best follows the comprehensive conversion of self-pay advanced procedures. Now, you can absolutely charge for these if you're doing more of a detailed, and as I shared for you, portion of my clinic does look that, and with a lot of our clients who have more volume in their clinics or multi-doctors, or they have one person in the clinic doing that, you can say, Dr. A, I'm concerned, I want you to go to Dr. B, they're gonna run a full evaluation, and then your team can come behind, let them know what those fees are, and they can be, credited towards an in-office therapy if they find that they need those. And so that model serves best mostly with if you're bringing people back because you want that exam element to look and feel different. So if you're going to charge, you want to make sure that there is a different element than what they normally get at every single visit. And so if you have something like your MMP9s or additional testing that you want to charge, you should be compensated for that. And you can figure out, again, the elements that change your clinical decision making, compile that into what your protocol will look like, and then have an associated fee according to that. So once you figure out what you want your clinic to look like and how you want your clinic to run, you can use that data to have clear communication with your patients. And so the second most important shared element that you're going to see in top performing practices is they have learned to communicate with their patients. And so all of us are scared of or concerned about, being the cheesy used salesman, car salesman, on the bottom right-hand image that we see. That's what most people get nervous about when we talk to clients constantly. This is their biggest question. The language of conversion. All of a sudden, things became self-pay for in-office procedures, and we got nervous to talk to our patients. And so these are some of the elements that I go over with clinics to make sure that you're effective in your communication. And you're going to be effective in your communication because you have data to support that. So if you screened your patient and you got the tools that made an impact on your clinical decision making, you're going to use that to have the conversation. So a couple elements that I like to review. Number one is you always want to lead with your unfiltered opinion. And in just a moment, I'm going to show you some glands and how I approach patients with this conversation. But let them know how you're feeling. Are you concerned? Are you not concerned? Do they look better than you thought? Do they look worse than you thought? Are they a contact lens wearer and we need to associate those? Is their vision blurring, at the computer? Go ahead and let them know what your thoughts are. I have kidney stones that are the size of a golf ball, and the first thing that the technician did was run them, and I wanted to know immediately what his thoughts were. And of course, technicians never want to tell you because they always say they have to run it, but they see it all the time, right? And you will get this information right when you take it. They're going to ask the technicians what those look like. So when you come into the room, give them your unfiltered opinion of what the status of their glands look like. It doesn't matter what tests we're running in the office. Even topography we run today, throw the image up, the first patient's like, what's going on with that, right? So they want to know if they should be concerned. And you want to provide them out the gate that information so they can get to the same story that you're trying to kind of depict. So the next thing you want to do is simplify your conversations. And so we've all talked to patients and we're knee deep into what these glands are, or knee deep into what glaucoma is and macular degeneration, and their eyes have just glazed over. And that means you have lost them. So it's important to be clear and concise in your conversation, especially if you're having these conversations more frequently because you're screening more of the population. You're going to encounter what I like to call dry eye fatigue. You'll start having these conversations so much that you're kind of tired of having them. And that's because ocular surface disease is out there. And if you're not exhausting these conversations over and over and over, I am telling you, you are missing it, which also means that you're missing a large potential for your practice and revenue that can be added to your clinic. And so the more that you become exhausted in these conversations, because most people tend to over explain it, you get fatigued and then you become concise. And so you can have these conversations in less than a minute and a half. I have timed myself. I have videotaped myself for clients to show them this is a demonstration of how to be clear and concise. And so when you're going over the images, as I kind of previously mentioned, you want to correlate the objective findings with any symptoms. So this can validate how they are feeling, right? So if they're noticing their vision blurring when they're using the computer, if their contact lenses get, dry towards the end of the day, if they're, stinging on occasion, all of these things that they're kind of mentioning without knowing it, you can show them the clinical findings and say, this is why you're having that trouble. And then they get that aha moment. They were looking for the answer and you have provided to them clear and concise. That will allow you to prescribe objectively. This is probably the biggest thing that I tend to see. And so sometimes you get in cases very similar to glaucoma where it's not clear cut. It lives in this gray zone. And some of the cases with OSD, that's the case. There's a couple options that you can approach. And if you're thinking to yourself, what's the best approach for this? And so I commonly will tell my patient, if you see me thinking, I'm trying to figure out what would I do if this was my eye? And I don't have to do that frequently because most cases are very clear cut as to what is needed. But if you get stuck with those, I will challenge you. Oftentimes you're going to prescribe the best method for them. Unfiltered, without looking at their pockets, if you think they're going to pay for it, just look at the scans, look at the data that is provided to you and prescribe based off of the severity of the case. If they have dysfunction with the meibomian glands, if you're seeing some aqueous changes, if there's staining on the cornea, that way the patient understands what the journey will look like. And so after you've done those two things, you need to step back. You should have a treatment liaison that you can introduce, and they should be able to pick up the conversation from there and then carry on with the patient. I have found, and I'm sure you guys all go through this, that as you talk to the patient and you tell them, is there any more questions? And they say, no, I'm great. And you leave the room and someone else comes back, in. It doesn't matter if it's even just like the type of coating on your glasses. They're like, what did she say? What is he saying? And they still didn't get it. And from peer to peer, they really need to have that conversation. And so if you kind of follow this train of thought, it will keep you in track of communicating properly with patients. What is your opinion? Provide them the information of what you're seeing, clear and concise. Don't over-explain it. Validate what they are noticing and prescribe objectively. After that, allow your team to come in and take over from that point of view. And so that's how the language of conversion really helps. And of course, there's a little bit more of an art to that, but those are the key elements that will get you moving so that you can screen more of the population without getting too far behind. So say we take this meibography and I'm presented with a 30-year-old patient and she's a contact lens wearer and she comes in. These images may be on the top screen of my exam room and I'll throw them up and typically I'll say, does the team go over this with you? Because my team has seen these so much they can describe them in great detail. And if they say no, I just say that, I want to review them and I can say, hey, Kelly, I'm really concerned about these, especially for how young and healthy you are, especially being a contact lens wearer. So many people are unaware within the eyelid, there are oil glands. And these oil glands, I want you to think of them like windshield wiper fluid. With the blink of the eye, you should push like an olive oil to the substance, and that's going to provide your lubrication. Now, the bottom image here shows us what they should look like, long, straight, and narrow. And over time, you can start to see those gray patches. Those are glands that have died over time. And you can see your image is in that severe category. You've lost at least 50% of them. And this is concerning, again, because you're a contact lens wearer. And the changes to these glands are one of the #1 reasons people have to stop wearing their contact lenses over time. So with that brief conversation, I've cued them into the fact of there's oil glands that they may have never known of. And commonly I'll tell them, just like a dentist would review kind of underneath the tissue what's going on, this is our version of looking for cavities, right? And they look for cavities on every patient, whether you have pain or not. And sometimes I tell them that waiting to treat these would be like waiting to make sure if you have pain. So I always say my biggest victory is treating asymptomatic patients, showing them an objective issue and going, something needs to be done about this. And so when you prescribe, you are prescribing objectively. The symptoms, whether they correlate, help validate that. But I commonly will tell my patient base, by time you notice the symptoms, your eye's already inflamed. And that is the case. They should have more homeostasis where the patient should be able, 30-year-old patient should be able to wear daily lenses without any trouble. And commonly what we do is change contacts and change contacts, where treating the root cause of the problem would be a better approach in getting the patient a long-lasting relief. And so once we've established proper screening protocols and we have clear communication to the patient in regards to what's going on and what we need to do about it, the last thing we need to do is have a handoff. We can prescribe everything and tell them everything we know about their glands. And sometimes they'll have additional questions and you can get into that. Now they really have information that they want to know. But oftentimes I do leave that to my team. And the only reason I'm able to leave that to my team is because I've invested time in training them. So the third most important shared element in top performing practices is team training. And this is one, aside from screening, the biggest pit that I tend to see in a lot of practices. And people ask all the time, what's the biggest ROI on devices? And what can I expect? And I always say your biggest ROI is your team. So I challenge you today and ask you, how often do you meet or train your team? And if you're in option A, where you don't even know what a team training is, it's time to likely have one. But then the question is, if you combine the first to the second column, how long do you meet with your team? So do you meet once a week for a morning huddle? Is that enough time to train them properly in some of these more advanced treatments? And that's where you really want to kind of get them to elevate, because you're going to find that investment into your team helps lighten your load. So when I taught my team how to refract, my quality of life improved exponentially. And then I thought to myself, why didn't I do this sooner, right? And so 6 years into Carolina Eye Doctors, I can tell you between my two columns, I do team training at least a half a day to a day every week. And I thought to myself, gosh, I could be making money and we can put patients on the book. And every time I sat down and trained them on something new, whether it was my contact lenses that my contact lens technician is doing, whether it was refracting, whether it was myopia management, whether it was the conversations, I found that my life got better. The clinic became more effective and more profitable. And so anytime that you ask to see a profitable office, I always say that a proficient office is backed by a well-trained team. Exponentially, my life improves the more veteran my team has become. And so if you don't currently set out time, it's like saying, you're going to be both the doctor, the technician, and the optician. Your team has to be trained on how to educate your patients on why this is important, the cost associated, and then from there, that foundational knowledge can expand into a little bit more. So if you haven't trained your team and you're either wanting to advance your offerings as far as in-office procedures, or if you're maybe doing a little lukewarm and you're thinking, what else can I do better? I would suggest set out a lunchtime. If a half a day seems absolutely impossible and you're wondering, how do I even get this to perform? Just start with a lunch break, start with a morning and have a clear and concise conversation. We're going to go over what OSD is and why it's important to identify it and treat it. If your team doesn't understand that, they're not going to understand the why. If you provide them the why, they're going to figure out the how to get it. And so that is one of the easiest things that you can invest into your team is, hey, this is what I'm looking for, and this is why I'm looking for it. Actually, patients will ask all the time, if I just decide to do nothing, what will happen? And I always think that question is quite interesting, because who just doesn't do anything, right? Who goes to the dentist and goes, nah, I just don't like any of those options. What do you think will happen? And they're going to, well, you're going to lose all your teeth, right? And so it's hard to say that you are going to go from just having some plaque and tartar all the way to needing a root canal, but there's a spectrum on there that we need to let them know that the terms that result in dry eye, that seems to lessen the condition. That's why we use inflammation. And so their eyes are inflamed and the cornea can start to have a decrease in their turnover. And so simplify these terms where they can then use it with their patients so the patients feel like they're speaking peer to peer. Once you provide them that foundational knowledge, I can guarantee you're going to be able to identify the candidates. And this has happened in my office, not just for OSD, but for neuro lenses, for myopia management. We don't look at a 7 or 8 year old that is plano anymore like we used to, because now we have axial length, right? And so they become more than just robots. They start to have a thought process behind what they're going to do next, and maybe the conversations that they're going to have with the patient. And the more that these conversations exist before you get into the exam room, the easier it is for you to have that dialogue on why something needs to happen. So just like my team knows, breed keratoconic patients in the office, whether they are diagnosed or not diagnosed. And if they sit in the autorefractor and they see that the Myers are not as clear, they go right to the topography. If your team sees that there is on the fundus photography, maybe something on the back that needs additional, you can send them right over to the OCT. But they need to be taught that. In order to be taught that, they need to be trained, right? And so once those two have been kind of set as far as a foundation, then they become proficient in their skill set. If you have a keratograph or any other, diagnostic tool in your office and you haven't taught them how to be proficient, if you're only screening people and you're expecting them to run this entire elaborate dry eye report or even just myography, and they only run it one scan once a day, one scan once a week, it's going to slow them down. They may forget how to simply just put a name in. If they run it continuously, and I normally find do 3 and you'll be perfectly fine when we train teams, and this is something that we do in ODI, we train teams, it's that important, and they say there's no way we're gonna flip the lid. We say, yes, you're gonna flip the lid, and then they go from being concerned to being empowered. And that really sets the trajectory for getting your team to back you on the endeavor of identifying and treating patients. There's a reason that you've invested in technology or considering getting an additional technology, because it's important to treat. It is a disease process, but we have to find a way to communicate that to our patients. So beyond just identifying patients, they can become treatment liaisons, which means they're now proficient in the conversation of in-office therapies, articulate their benefits, why it's important to do them, and what that journey looks like. They can become more proficient on having the conversation about cost. In ODI, we go over this 5-step approach on training them how to have these conversations. Again, you just can't throw them into a room and just say, I want you to tell them about this $2,000 treatment. They're gonna just freeze up. But if you give them steps on that conversation, and I always say, we're not salespeople, and unlike your optical and your contact lenses, this is something that's more like a treatment. So you want them to be viewed more like a surgical coordinator than you do want them to be on a sales floor. But you have to provide them that foundation. Surgical coordinators have a recipe that they go through when they're getting you on the books, what options are available. So if you think of cataract surgery, all the different elements that they can upgrade into, there's costs associated, but it's surrounded by education. And then that educational foundation provides the need for treatment. And then once you get kind of past the liaison, they can become OD extenders, which means depending on the in-office therapies that you have as far as offering, they may be able to, and depending state by state, they may be able to administer some of these tests. So get them set up for, tier care, get them prepped for IPLs. If you have an esthetician, maybe do IPL in your state. So all of that really helps provide. I found very quickly, I thought that I was needed for all the things in my office, right? The patient needed me to perform it. They needed me to, get their contact lenses going. And as I stepped further and further away from this, just because of the demand, I needed to keep seeing patients, and I kept training my team. I was really shocked on how little my patients actually needed me. They needed me to identify and provide a treatment plan, but not exactly execute the conversation around it or getting them scheduled, or in some cases, even the treatment itself. And so in order to be successful with that, you have to have a well-trained team to back you up in that conversation. So by implementing a robust screening protocol, it naturally adds as a catalyst for any in-office therapies that you may currently have or be looking to add. And so although during this topic, I really have gone over how to use the keratograph or things to consider in your screening tools for identifying what type of OSD you may be encountering and maybe determining it as a treatment tool. So are they mild, moderate to severe, what that case may look like. It also helps you set up the expectation for that treatment. But I also want to kind of just touch on the topic of how you can use it to monitor progress. And so if you've already set your screening protocols, and by taking a look at the data, you can prescribe effectively based off the severity, you then use your keratograph to monitor the conversation. So it does allow for repeatable parameters that can be compared over time and track their response to treatment. These patients are now your patients. I always say your patient doesn't become your patient until they pay you their cash. So if you're getting them in by VCPs and they start paying you their cash pay procedure, now they're your patient and not the VCP patients. So when they start electing to advance therapies that are not covered by insurance, it's a different element as far as making sure you're setting the expectation and outcomes for the treatment that you have prescribed. And so it helps aid in difficult conversations. It's why screening is very important. So I tend to use the word disconnect. Maybe some people are feeling better than the surface looks. That's a different conversation than they're feeling bad, but the surface is looking better. So maybe their, tear breakup time used to be a 6 and now it's an 8. It's getting better. So you can show them maybe the staining on the surface of the eye was a grade 3, but now it's a grade 1. So it gives you those objective things to say, hey, it's actually improving, and that way they can carry on those conversations beyond just symptom scores. So if you repeat those symptom scores, sometimes patients are like, no, I feel the same, when really their speed score may have dropped from a 13 to an 8. But everything is relative to how they feel over time. So on kind of shaping the Keratograph, not only as a screening tool, but also help aid in the type of treatment, can then be used in that third element as far as monitoring progress. So some of the things I just want to kind of recap on is the flow in which I challenge you to take a look at your clinic and determine which elements you think can be altered to improve outcomes. And so if someone's just getting started with advanced services, we always start with setting the foundation, and that is always logistics for our ODI team. And a lot of that is centered around screening. Without properly screening, you do not identify, which seems that you cannot have the conversations, which means you cannot get to the treatment approach. And so taking a look at your screening protocols and setting those, not one-off scenarios, but providing clear cut to your team what needs to be performed is important. Start off by just establishing what kind of clinic type are you looking to establish. Do you want to prescribe treatment plans from your annuals? You will be very surprised by how many patients are really ready to make that call as far as an investment of in-office procedures right there. Oftentimes they're looking for an answer, you have shown it to them and they're ready to get moving. Or do you want to bring people back? Do you simply not have enough time? Do you have a multi-doctor location where one person is primarily doing it? Make your associate very simply but effectively say, hey, I'm concerned. I really need Dr. Smith to take a look at this. Well, if that patient trusts you as their doctor and you say, go see Dr. Smith, they're going to go there, right? But in order to reduce no-show rates, that may be something you want to consider having an exam fee set for. So once you've established that and set your protocols as far as which elements change your clinical decision making, don't do all of them. Don't have to explain all of them off, but determine what looks best for your clinic to make it efficient and proficient. You have to train your team to do that. So you get those elements, you prescribe objectively based off of what you're seeing, and then you can repeat that over time to watch their progress. And so I think that as you challenge your clinics to take to the next step, you really have to look at the flow of the clinic, and it may evolve based off of the demand. For me, that's essentially what happened. I found how valuable some of the data was. I tried it in one way, and we're constantly evolving this in the clinic based off of the need of the clinic and the volume at the time. So I wanted to kind of share with you essentially how vital the Keratograph is. I always think that as far as the more powerful tools that we have for conversion for in-office therapy, as the majority of us look into offering those as far as advanced services, the two biggest elements that I tend to see, number one is a Keratograph. It has all of those elements kind of set in them with, my biography set in, and then the crystal tear report that can be run. But it also combines the second most powerful tool as far as diagnostic goes, which is imaging, right? So instead of having to constantly describe to patients, there's this thing, I see this, you can show them a picture and immediately they're cued into where they are. So you can have that conversation around why a treatment is necessary, not what is this and why do I care about it. You can show them, this is where we're at, this is why it's necessary. Let's talk about how we need to resolve it. So hopefully today, after this talk, you can challenge your clinic, take in some of those elements, implement them, and constantly revisit those items as far as screening. Challenge yourself on the conversion discussions that you're having with your patients, and then really sit with your team and retrain, constantly retrain to elevate them to the next level to improve maybe your offerings as far as your conversions with your patients, or have proof of concept if that's something you're looking to bring on board. That way, all the elements are already set and you'll hit the ground running once you implement any of those advanced services. So I want to thank Bill for having me on. I know there may be some questions that we want to review, and I'm happy to take those at any time.
Wow, Chantel, that was amazing. So much information. In fact, you've answered almost all the questions that were submitted, but I have a couple of things that I wanted to ask you. Regarding the treatment liaison person, the handoff that you do, does most doctors that I know always have a difficult time talking about money, especially when it comes to non-covered services and money, and learning how to do that is a skill set that is not taught in optometry school and is something that some people can master and some people can't. Do you leave all those conversations to the liaison that you hand off to, or do you have those conversations with your patient in the chair when it comes to treatment recommendations?
So I do leave those to my liaison. Now, if someone asks me a direct question, and normally the patient's not going to ask you the exact amount. Their biggest question is usually this: is it covered by my insurance?
Right.
And so I can give you the easiest way out. And we simply say to them, insurance do not cover advanced procedures. And that gives them the answers that they're looking for. Now, through ODI, one of the things that we constantly talk about is that you have to have, most people want to do what's best for them. That's not the question. What the question is how I'm going to pay for it. A lot of things these days are not covered by insurances, and they're always used to complaining about insurances because they're just, things are not covered, especially advanced procedures. So I always say insurances do not cover advanced procedures, and they're going to turn around and ask your team that exact thing. And that's what we train teams to say, is that they don't cover advanced procedures. And so that makes that conversation, leave it there. Actually, during the conversation, when I have liaisons speak to the patient, I already have the liaisons say that, so that they don't have to get in this awkward conversation of, is it covered? You just have the liaison say, this is what the doctor prescribed. It's not covered by insurance. But the third piece of that is, well, then how do I pay for it? So most people want to know, how do I pay for it? So there are financing options that are available. And then your liaisons can go into that. And so you can consider things like payment plans within the office, or offering care credit, or offering a cash pay discount at all one time. But we commonly will find that most people understand the necessity and they want it. They wish it was covered by insurance. But if I still want it, how do I get it? What's that journey look like if I can't afford it all at one time? And so I would always follow that up by saying, we do have some financing options that are available. I'm going to have my team go over in detail, everything we talked about and what the schedule looks like. And you can kind of excuse yourself from there. We do have clients that are like, I'm just going to flat out tell them. And so they'll let them know what that cost looks like. And the reason, and I think all of us have become more comfortable with that, is because we have dialogue. There's other of us that don't even want to talk about a $10 copayment, right? And they're like, oh, we got to check on that. We all know our fee structures, but we normally leave that with someone else. So I think it's always interesting when all of a sudden, when I started out, and I should say that my Keratograph is what set the foundation and the need for me to offer in-office procedures. I was running my biography, I was realizing this necessity of it, and I was like, I have to do something about this. So I started with tear care. And after that, I had, more gland loss and cases that were more advanced, and I was like, I got to do something extra. And so we brought in intensive slide. Then I was like, I need to do more. And so it was basically answering a necessity that was always in my chair that I was just missing because I wasn't screening it. But when we started doing it, I looked at my technician and I said, since when did these people have thousands of dollars? My same patients that complained about $10 copayments and $200 pairs of glasses always have this money. And it's because they view it differently. This is a disease, this is a treatment. It's not just online shopping for glasses. And so it would be very similar, Bill, if we all went to the dentist and they're like, you need a root canal. And so they all know that there's going to be a large expense set by the dental component, and it's going to be, well, how do I pay for it, right? And that's, I think, where the conversation needs to move into. So I think by just addressing it out front with, doesn't cover advanced procedures, and that is the truth by it, and there are some financing options, then you can disarm them. They already know that information. So now their brains have moved into, okay, what are those options? And if they're interested, they're going to ask your team about them. And that's likely the case. I find that a lot of people say, maybe no, not right now. But if you continue to provide the foundation of a disease process that is chronic and progressive, right? I always tell them, you probably have a little bit more redness than you did 5 years ago. Then they really understand, like, this is I have to do something about this, but I maybe need to get my finances in order. If an HSA is pulling over, that's something else they can look into. But as the doctor, you can kind of just disarm by saying, insurance doesn't cover advanced procedures, but there are some options that my team, I want them to review not only what we've discussed, but the scheduling and what those look like.
It's interesting. A lot of what you said, especially in the beginning of your presentation, mirrored my experience when I first started using the Keratograph. I would screen patients with way too many tests, and it gave me more information than I needed, and it really bogged down the clinic a lot. And then it got to the point where my technicians were pushing back and didn't want to do it at all. And we slowly, it took about 2 years to figure out what do we really need to do. And we got it down to 2 very basic tests, one a questionnaire and one test on the Keratograph, just as done on all routine adult exams, like you said. And I think that was a game changer when that became like doing an auto refraction or an Eden photo or whatever, all the basic tests that you do. And once we got that mindset in the clinic that this is just necessary, this is what we need to do that. And also not having the conversation about dry eye during a vision care plan exam and having them come back for that medical evaluation that's a charged visit. I think that was a difficult transition for me as a physician, because for 25 years I had that conversation about treatments during those examinations. So undoing all the damage that I was doing and all the wrong things I was doing was probably the hardest thing to learn. We have a question from the audience that goes a little bit outside of what we talked about today, but it has to do with scleral lenses and dry eye.
Okay.
I assume that you fit scleral lenses for dry eye. I know you fit scleral lenses, but I assume you do it for dry eye also. The question has to do with reimbursement. And the question is it typically covered by insurance, or is it a self-pay thing? And how do you typically handle patients who can benefit from scleral lens therapy for dry eye?
It's interesting how successful I started with the hat of a cornea and contact lens specialist as a fitter, constantly just rehabbing tertiary care. And I was like every practitioner who wanted to offer, just the right level of advancements that were also cost effective. I think that's just innate to being a provider and taking care of people. And then it wasn't until that I got the Keratograph and I was like, okay, I'm running all these tests and I'm like, I'm figuring out something else. And then I found the need. So I provided some in-office therapies that was my first step into not covered by insurance. Up until that point, everything kind of had an insurance association. And so TierCare at the time was my first not covered by insurance. And I was like, well, we'll see how this goes. It didn't take me long before I went from TierCare to Intense Pulse Light, because actually by bringing on Intense Pulse Light, something different occurred. And it wasn't my clinic, it was me. As you said, Bill, we were the problem. And the language you use in prescribing really makes a difference. Simple words like unfortunately. You'll never hear me say, unfortunately, it's not covered by insurance, because I'm not the insurance company, and I feel like I should be paid my fees. And so we just say they don't cover advanced procedures. And so that's what I found changed. It was myself as the practitioner. And so now there was something that was an advanced procedure that I had to offer that wasn't covered by insurance. And I realized people were willing to pay. They were willing to pay for things that worked, that had a clinical foundation that they understood, as long as it matched their expectation of treatment. And that's a totally different conversation for sure. And the reason that's a long-winded conversation actually ties back into what we're doing is that I learned so much with self-pay procedures from my Keratograph and how I set up my dry eye portion of my practice, that I went back to my contact lens side and started prescribing differently. So I've been an iPrint provider since Chris started iPrint. I was one of the top 5, and at the time when they told me to put goo in someone's eye, I was like, I don't understand what you're telling me to do. And of course, that's a hefty cost. There's impression fees. The lenses are more expensive. And at the time, I was really reserving it for just those special cases, right? And then as I saw my dry eye side succeed tremendously, I started thinking to myself, why not present the offering to my contact lens patients? And so I felt strong based off of the data that I was seeing that impression technology for these lenses was outperforming any other technology I had previously used. And I shouldn't reserve it just for those, end cases. I should provide them the option. And if it's financially feasible, let them elect. And what I realized is people said yes, with the idea of how do I finance it? And so to answer that long-winded conversation, I'm always sensitive to audits. I always perform my clinic in the black and white zone, never in the gray zone. And I think as a practitioner, I've changed my mind because I realized people are willing to do that. And so now my office, from impression lenses from an eye print and eye fit side, is about 80% impressions compared to some of my more conventional lenses that I was doing. I did a big 180 on that. And so when it comes to for dry eye, for scleral lenses for dry eye, yes, there are things like VSP that have those codes. Sometimes that iMed is an absolute, just takes forever, not even worth it. I stopped doing the gray zone options. And so if that person wants to reach out to me, I'm happy to show them where it is covered and what cases you need to use and what line box item you have to fill out. And I used to do it much more than I currently do it now because there are all those cases, even things like, at high prescriptions, like your plus and minus 10s that used to be covered. Well, they are, but they cut reimbursements dramatically. So the question is, do you want to get into that? And that's why I started looking. And so as my practice, I retreated from that. And I retreated because I realized people were willing to pay for things that worked if you provide them the opportunity. If you don't provide them the opportunity with the clinical foundation as to why this is different, why it is better, then they don't elect into it. So that is a yes and no answer. I previously do it quite a bit, especially for Sjogren cases. That is an absolute, it's even listed as one of the therapeutic options. But now I would say in the past 3 years, I really do reserve it mostly for my cones, where it's set in there. And again, I do a lot of impressions. And so even when insurance is covered with a $10 copayment, if I give people the option and I'm saying, if you have the opportunity, if it's financially feasible, without a question, this is what I would do and this is why I would do it. And give them the options. Majority of people are like, of course I want the best for my eyes. How do I pay for it? And so that's kind of how I transitioned that. And I learned it from the dry eye portion of my practice that had proof of concept that people were willing to pay for things. My same patient base, I just didn't know all these years because I was looking through the lens of their wallets. And I needed to, I always, my husband has a heart condition and I'm like, he never goes to the cardiologist and goes, what's the cheapest option for me? But as eye care providers, we're always like, this is the most cost effective. And I urge to say, what is the best option, period? Prescribe that and then give them the options below them. They still exist, but some people are like, I'll be back, or I want to start here. I definitely want to do that. And so they're planning for it because maybe they weren't expecting that initial charge.
So I want to close with my final question, and it kind of gets back to how we met and how I got to know you and got to know Shane. Can you just tell us what OD Immersion is and what you guys do?
Yeah, so OD Immersion, as you kind of mentioned, was early on designed to simplify integrating and implementing advanced procedures in a primary care setting. And so as we were on the lecture circuit, kind of trailblazing and getting this information up and running, we met each other and realized that there needed to be a company that worked for the private practice, as far as clear transparency on devices to bring in and then how to implement them. And so these are large investments, and we commonly met people who invested into them and simply failed to plan. And it didn't matter if it was a LipiFlow or an intense pulse light unit. Oftentimes people invested into great things and then just didn't have the time. We all go to meetings and we get really excited and then we come back and then we get bogged down by our just everyday clinical settings. And so it is a new field for sure. We're investing quite a bit in it. And we just found that, practices needed help on figuring out all of the things and some of the things we talked about as far as the logistics and what does this look like for me? So we set ROIs for practices. We have benchmarks for them. We go through, these are the pillars that we need to set up within the clinic. As you mentioned, just the simple conversations on looking through exam elements and things like we talked about today with conversing on how do I get patients to understand without salesy? What do I bring up the topic? Team training is a big thing. We train teams all the time. You may not have time for it. We have time to do that. And so we make sure that we hit these benchmarks so that the clinics can keep running, but you have an initiative that never really takes a backseat, which is commonly what we tend to do. And then once you kind of get that all set, we get to the treatment aspect of stuff. And so with things like intense pulse light, certainly, it really found a need when intense pulse light took off a little bit, just because there's a lot of precautions that we need to take, and there's a lot of side effects to them, and people started to lack confidence in their devices. They started to lack confidence in the clinical cases, and now you have people paying thousands of dollars, and a lot of us were not trained on this technology. We're decades out of school. We didn't learn it, and now people are paying cash pay. So they're like, I understand the need. I bought the device. They're now paying me. How do I give them a safe and effective treatment? And so we take in clinical cases, we'll guide them through those conversations. And once people kind of establish those, they find themselves in the world of aesthetics. When you buy the devices, you all of a sudden also turn on the hat of a dermatologist in the patient's eyes. And so there's a whole new language of these devices and how the two of them correlate, and they're big investments. So OD Immersion was really set as an advising company specifically in the field to determine what tools. Keratograph is high on our list. We'll see a lot of people who jump right into, I know I wanted to get in the field, I bought this device, it's not working. And we're like, well, what are you doing to get it to work? And maybe they have a Keratograph, they haven't turned it on, they have no screening protocols, and we're like, you have to go back, identify those people, set the protocols for them, and then that way you can watch their progress and effectively and safely get patients treatments with the outcomes they're anticipating after they paid you cash for it, right? You don't want to get to the end of the treatments and go, well, darn, that didn't work out well, but you have to guide them and coach them through. This is not going to be a 4-session deal. You're really severe, it's going to look more like 6 months. And what's that conversation look like? How do I set up my fee structures for those? And then kind of guide yourself as you start. And it's always the entry point to it. These devices, they determine proof of concept. They exist in the clinic. A lot of questions we get is, where do you get referrals for? And I go, they're in your chair. And we have a conversion that we work based off of how many annual patients you see. You just have to go sniff them out and have those conversations. And so OD Immersion has been around for a couple of years, really guiding clients through the nation as far as getting up and running quicker to their ROIs and ensuring that they're getting safe and effective treatments.
Yeah, I will say that the majority of the device manufacturers out there that create and sell these very expensive devices are not experts at business implementation. And that's what I found you and Shane really brought to the table and helped the doctors understand how to really make the most out of their equipment. So I want to thank you so much for this presentation tonight. It's been fantastic. I've learned so much, and I want to thank everyone for staying a little bit overtime tonight. And we'll see you again soon for the next Oculus Clinical webinar. Have a great night.
Thank you.
Thanks.